All right. Hello, everyone. So my name is Edwin Shrabieh. I'm a plastic and reconstructive surgery resident at the American University of Beirut. And today I'll be explaining the topic of the evolution of cleft lip repair. So whoever wants to really understand the basics of cleft lip, from the embryology to how we result in a cleft lip, to the evolution of the methods of the cleft lip, this presentation will be right for you. All right. So this is the outline. First, I'll be talking about the epidemiology, the etiology, then the embryology, the anatomy of the normal lip versus the anatomy of a cleft lip. I will classify the cleft lips, the pre-surgical molding, markings of the complete cleft lip. So first we'll start with the markings methods of the complete, then how to mark an incomplete cleft lip for the surgery, for the correction. Then we'll go into the lip dissection, the primary correction of the nasal deformity, closure, and bilateral cleft lip repair. So first we'll start by defining a cleft lip. So obviously it's a deformity of the upper lip. It can be a small notch or it can be very wide. It's the most common facial birth defect in the world. So some epidemiology, we could have a 2-to-1 male to female ratio for the cleft lip with palate, while it's a 2-to-1 female to male ratio for an isolated cleft palate. And this is usually due to delayed palatal shelves fusion. And as for cleft lip alone, we don't really have a difference between male to female ratio. The incidence can be between 0.2 to 2.3 per 1,000 births. And of course, it depends on the country of origin. So for example, Asians and Native Americans will have the highest incidence. They will take the 2.3, while the African Americans will have a lower, so the 0.2. And finally, the left unilateral cleft lip and palate. This is the most common configuration, so the left side. As for the etiology, so it is basically multifactorial. So it is environmental as well as genetic. So some environmental factors that would increase the probability of having a cleft lip. Of course, these are during pregnancy. So phenytoin exposure, it increases 10 times the normal risk. Maternal alcohol consumption, the use of Accutane, steroids, and maternal smoking. And finally, maternal folic acid is also a protective factor against having cleft lip. So first we'll start with the embryology. We have 5 facial prominences that forms the face. So we have the frontonasal prominence, we have 2 maxillary and 2 mandibular prominences. So this is what you guys need to know. And the maxillary and the mandibular, they come from the first pharyngeal arch, okay? While the frontonasal prominence, it is independent and comes from the neural crest mesenchyme. Now, what does the frontonasal prominence give rise to? It will give rise to the forehead, the nasal dorsum, the medial and the lateral nasal processes. So the medial nasal process is here, the lateral nasal process is here. This medial nasal process, what it will give rise to? It will give rise to the nasal tip, the columella, the philtrum, and the premaxilla. And how it does this is by fusion, and we will see how later. While the lateral nasal process just stays, it just gives rise to the nasal ala. So just a quick explanation. This is the maxillary prominence. What it will do, it will push the medial nasal process in the middle to fuse, and then the fusion of the medial nasal processes, this is what will give rise to the nasal tip, the columella, the philtrum, and the premaxilla. So basically at the 4th week, we will start having these nasal placodes. Then the nasal placodes will start dividing into the lateral and the medial nasal processes. Then as you can see here, this is the maxillary prominence. It will push inwards. And then finally, while pushing it inwards, it will cause these medial nasal processes to fuse, and they will give us the intermaxillary segment. So the intermaxillary segment is basically formed by the fusion of the medial nasal processes. So as we can see, this is the intermaxillary segment. We can see it here, and it's basically made up of a outer label component that gives us the philtrum and an inner bony palatal component that includes the 4 maxillary incisors and the primary palate, which is anterior to the incisive foramen. Okay, so we can appreciate this intermaxillary process in a bilateral complete cleft lip. So we can see this is basically the intermaxillary segment. It's made up of a philtrum, okay, and the bony aspect of it. So, as we were discussing, the upper lip is made up of the fusion of the intermaxillary segment. So, once the nasal processes, once they fuse in the middle, we have the intermaxillary segment. Then, once the maxillary prominence it fuses with this intermaxillary prominence, this is what will give us the completion of the upper lip. So the upper lip is basically made up of the maxillary prominence and the intermaxillary prominence in the middle. Fusion of any of these sides, it will result in a cleft lip. So this is basically how a cleft lip occurs. So what's the difference between a complete versus incomplete? It's basically the degree of lack of fusion. So if there's a very large lack of fusion of the maxillary prominence with the intermaxillary segment, we will have a complete one, while if it's not really a total, if it's a partial failure of fusion, we will have an incomplete. So now we'll talk about the palatogenesis. So palatogenesis occurs with the fusion of the maxillary prominence. So basically they start together because they are actually a part of the maxillary prominence. So as you can see, this is the maxilla, and these are the palatal selves. So as the maxillary prominences are growing towards the middle, the palatal shelves are also doing so. So we have initial growth of the palatal shelves that first starts obliquely downward and then it goes horizontally. Then they fuse in the midline with the nasal septum, and the failure of fusion, this is what will give us the cleft palate. And usually the right shelf fuses before the left, and this is why, as we said before, the left complete cleft is always more common than the right side. So basically, what is the relationship between the cleft lip and palate? As you can see here, in cleft lips, the misalignment of the maxillary segment can mechanically prevent the palate to fuse properly. So here, if we have a misalignment here, it will affect the alignment here also, and it will result in cleft palate. So a cleft lip can also result in a cleft palate. While an isolated cleft palate, which usually occurs in females, often has different mechanism, which is then genetic or hormonal, or sometimes, for example, a large tongue in conditions where babies are born with a large tongue. This might hinder also the fusion of the palatal shelves and cause a isolated cleft palate. So to conclude the embryology part, cleft lip is caused by failure of fusion of the maxillary prominence with the intermaxillary process. So a cleft lip with a cleft palate. The cleft palate is a product of a misalignment and translated into the palatine shelf. An isolated cleft palate, as we discussed earlier, is caused by another mechanism, such as a mechanical obstruction, where we have a large tongue, for example, or due to hormonal causes. So now we'll discuss the normal lip versus the cleft lip anatomy. The normal lip anatomy, first of all, we have the dry versus the wet vermilion. Okay, so this is the vermilion, we have the dry side and the wet side. There's the red line that joins the dry and wet. Cupid's bow, as you can see here. The tubercle, which is the middle portion. We have the white roll, which is an area of keratinized area above the vermilion. The filtrum column, so it's the this is the column right here, and the dimple, which is the depression between both columns. So the anatomy of the orbicularis oris muscle, we have the superficial and the deep fibers. So as you can see here, this is the deep fibers and the superficial fibers, which are interlaced, and we will explain shortly its significance. So the deep part, it runs in the vermilion, so it runs in the red part of the lip. It helps in curling the lower border on itself, which helps in inverting the mucous membrane, and its function is basically a sphincter function. While the superficial part is divided into lower and upper bundle, and it's basically its function is for facial expressions. So first we will start with the lower bundle. So the lower bundle receives its fibers from mainly the DA O, the depressor anguli oris. So it's made up of long and short fibers. So let's say, for example, the lower bundle of the Orbicularis oris is coming from this side. It has short fibers that will attach to this side, the first side of the filtral column, while it has longer fibers that will go to the contralateral column and attach there. And what this will do is, first of all, it will cause the columns, it will cause the formation of the columns actually, because it will cause them to rise when we have a force of tension from its long fibers that is pushing towards this side, and the fibers from the right side, the short fibers pushing also opposite to it. This will form a column. So this is the formation of the column, while the formation of the filtral dimple, as you can see here, is because of the paucity and the low concentration of muscles that we have in the middle. It's because of the decussation, because not all fibers decussate to the other side. We have a few long fibers that will decussate in the middle, and thus we will have here an emptier area which will form the filtral dimple. So as for the upper bundle, it receives fibers from a lot of surrounding muscles, from the zygomaticus major minor, the levator labii superioris, as well as the superius alici nasi, and finally the transverse nasalis muscle. So for the cleft lip anatomy, the muscle fibers will attach abnormally to the caudal nasal septum and the anterior nasal spine on the medial side. So on this side, we can see how the muscle abnormally attaches to the nasal septum as well as the anterior nasal spine, so the bone. On the lateral side, it will abnormally attach to the alar base, which will cause the ala to extend and to be depressed, and it also attaches to the piriform bone that underlies the nose. So from the outside, we can see the cleft lip deformity. First of all, we have a hypoplastic philtrum. So here the philtrum is very short. There's a displaced cupid bow, so instead of being horizontal, it's displaced upwards. The nasal tip, it will be displaced towards the cleft side, towards the cleft side, while the base of the columella will be pushed to the non-cleft side. Why? This is because the orbicularis oris will attach to the base of the septum here and push it medially. We'll have a very large dome on the cleft side. So as you can see here, this is because the lateral aspect of the deformity, which is here, we have the orbicularis attaching to the ala, the lateral ala, and it will cause this extension. Okay. Now, as for the classification of the cleft lip, so basically we classify it according to laterality, if it's unilateral or bilateral, and according to severity, if it is complete or incomplete. We will define the complete and the incomplete into further details, but just to touch on it. So the incomplete does not really involve the alveolus, and it does not extend into the nasal cell, while the complete cleft lip extends into the nasal floor and involves the alveolar bone. There are a lot of classification systems. I will only show you the Kernahan classification that was in 1958. So this is the simplest visual classification. As you can see, 1 and 4, it's a, first of all, the representation is a Y, okay, and it's divided into many parts that define locations for the cleft lip. So 1 and 4 are the locations of the lip, bilaterally, of course. 2 and 5, the alveolus. 3 and 6, the hard palate between the alveolus and the incisive foramen, so basically the primary palate. 7 and 8, the hard palate, the secondary hard palate, and 9 is the soft palate. So here we can see examples. For example, here, if it goes up to 6, so it goes up to the primary palate, the cleft. So this is a complete cleft lip up to the primary cleft palate. And here, for example, we do not have involvement of the lip, and so on. So the spectrum of cleft lip is wide. So actually we have incomplete, we have a subclassification of incomplete cleft lip that we also talk about. So A and B are examples of this incomplete. We have the complete cleft lip, the bilateral complete, the bilateral incomplete, and we have the mixed where we have a complete and then incomplete. So first we'll start with the spectrum of incomplete cleft lip. So it is defined, as we said, by an intact nasal sill as well as an intact alveolus, and it's subclassified. It was actually subclassified by Mullinken into a mini microform, microform, and minor form. So let's start with the mini microform. So in mini microform, we see that we started to have a notch in the side of the left, but this notch is still on the level of the basically what we look at is the peak of the Cupid's bow. So the peak on the Cupid's bow is equal to the peak on the Cupid's bow on the other side. So this is the mini microform. We can also start seeing a notch in the vermilion. You can see a depression. So we can see a depression starting in the philtrum. Also, we can see that the nasal cell started to depress. As for the microform, so this difference that we can see here in the Cupid's bow peak starts to form. So we have a difference, but this difference is less than 3 millimeters. And this is how we differ a micro from a mini microform. And of course, all other effects are present, but they are stronger in the microform. So as you can see, they are larger actually. So as we can see here, the notch is deeper. Here, the muscle now is even less expressed. So we have a smoother filtral ridge, and you can see here the nasal cell is more depressed, and the nose is starting to skew to one side. And finally, as for the minor form, as we can see here, all features are even more exaggerated, and what really defines it is the height of more than 3 millimeters in the difference in Cupid's bow peak, as it's different in height to the contralateral side. So, as for the complete cleft lip, so basically, the incomplete cleft lip, the cleft extends into the nasal cell and has an alveolar involvement. But we should also always be careful of the seminoid band. So this band usually can mistake us for an incomplete cleft, and this is only a band of mucosa that is made up of skin and mucosa. It does not have a muscle. Sometimes when we look from the exterior at a patient, we might think it is an incomplete cleft because of this seminoid band, but the trick is we should look at the alveolus, and once we see the cleft in the alveolus, we'll know that this is a complete, not an incomplete cleft lip. As for a bilateral cleft lip, so it's basically we can understand it from its name bilaterally. So we have either a complete or incomplete cleft on both sides. And just to note that we do not have here an orbicularis oris muscle. So this is called the prolabium in a bilateral. We do not have an orbicularis oris muscle that we will further discuss later its significance. Now let's shift to presurgical interventions. So basically, the goal of presurgical interventions is to minimize as much as possible the cleft lip. So it's to minimize the gap before going into surgery. So we use it from birth until 3 to 6 months of age. So this is the date when surgery will be applied. And it really aims to align, reshape, and minimize the gap and deformity before the intervention occurs. So we have two types, the active and the passive surgical molding. The passive, we have the lip taping, the NAM device we will talk about, the lip adhesion, and these rely on static tension, while the active, such as the Latham device, it exerts a progressive and tunable force that we will also see how. And these are effective early on because of high cartilage plasticity, because of the baby has still high maternal estrogen that allows this plasticity. So first, we will start with the nasoalveolar molding, the NAM device. This NAM device is an intraoral appliance with a bilobed nasal extension. So as we can see here, this is the intraoral appliance, and this is for the nose. It is inserted progressively into the mouth. So we every few weeks we change this shape um, uh, in order to mold and guide the alveolus so that it follows this arc, and finally it will be aligned by passive molding. And this bilobed nasal part, what it helps to do is it helps first of all to raise the tip of the nose to give it a shape. So the depressed lower lateral cartilage here will be better shaped and better formed, and also it gives length to the philtrum. So it's basically applied for 3 to 4 months, and its limitation is that it requires frequent visits to modify this nasoalveolar device, because as the baby is growing, we should change the. So basically, this is before NAM. We can see here how the prolabium is outside and misaligned, and this is after NAM. We can see how it is perfectly aligned. Another example, so here we can see from inside the alignment. This is before the NAM. We can see how they are misaligned, and after NAM, how it's beautifully aligned. We also have the silicone nasal conformer. So basically, its function is implied in its name. So this is the nasal conformer. We can see it in the nose. What it does, basically, it will mold the nose. So this is an example of a nostril at birth, and 3 months later before surgery, how it's beautifully molded. As for the presurgical molding device, the active one, which is called the LATAM, so this is the active type. We use a plaster cast of the upper jaw in order to know the size of the appliance. Then it is pinned to the maxillary shelf under a surgery, which is then general anesthesia. Then we place an elastic chain that will be attached to the premaxilla, and basically this is used in bilateral cleft lip repair. So what it will do, it will pull inwards this maxilla, and by rotating this, what it will do, it will also help in aligning the alveolus. And this is applied 4 to 6 weeks. Its limitation is that it causes secondary growth disturbance by restricting unwanted growth. So this is an example of before after using a LATAM device. We can see this is the prolabium, and this is actually, so this is the intermaxillary segment, and then we can see how it's beautifully aligned. And we also have the lip adhesion method. So what we do is we basically suture the lips together, and the mechanical forces by the soft tissue will reduce this alveolar gap, and will also try to mold and align the underlying alveolar bones. So by suturing these together. And this is also performed for 2 to 3 months before surgery. And finally, the simplest and most cost-effective method is the lip taping. So also implied by its name, basically we are taping the lips, and then we approach them together, and we can start as soon as soon as birth, basically. And it also includes a nasoalveolar, not nasoalveolar, a silicone molding devices for the nose, so we can apply a molding device inside a nasal conformer inside the nose. And the limitation is that it requires a role from the parents or the caregiver in order to always apply this lip taping thing, and also the baby does not have to intervene with it. Okay, so now we will discuss the surgical approach for the complete cleft lip. And then we will talk about the incomplete cleft lip surgical approach. And specifically here, I will be focusing first on the markings, and then we will focus on the other aspects of the surgical procedure. So the major problem that surgeons try to address is the discrepancy in height of the lateral and the medial filtering column. So we have the cleft lip offers us a deficiency or a short medial column on the cleft side, and this is what everyone tries to solve by doing variations of the incisions in surgery. So basically what they try to do is, we will see later, they try to add length from the lateral aspect into the medial aspect in order to try to lengthen the filtral column on the cleft side. So first, until the 1930s, the cleft margins were just sutured to themselves. So this was sutured to this end, and as we can see, the result is we have a shorter filtral column. So this will create a notch, and it will create what is called a Whistler deformity, because here the filtral column on the cleft side is shorter. Then came the Rose-Thompson technique. So it was based on the theory that straightening a curved line would offer us more length. So this is a curved line. When we straighten this curved line, it will offer us more length, but still we had two problems. The first one was a very long vertical scar that caused contraction. And the second problem was we still had a shorter lip, and thus we still had a notch. And this was only useful in microform clefts, so in small clefts, where the notching is very small. Then Le Mesurier's quadrangular flap came in. So this was in the 1950s, and basically the concept was using, as we said, a lateral tissue in order to fill in the medial aspect and to give it length. So as you can see, this is a rectangular flap. So he used a rectangular flap and inserted it here in the back cut. So this is the back cut. This is the rectangular flap. We can see how it is inserted, and what this will do, it will give length to the medial column. Okay. The disadvantage of it is that, as you can see, we have an obvious scar in the middle that crosses the philtrum. And then Tennyson and Dreddel came into play also. So what they did is basically the same thing, but a triangular flap to make the scar less obvious. So they are taking a triangular piece of tissue, inserting it here into the back cut. So basically the problem with both of these is the scar that crosses the lower side of the philtrum here in the middle. And thus Millard came into play the rotational advancement concept. It was in 1955, and the goal was to get rid of the incision that crosses the lower part of the philtrum. So now I will explain the markings of Millard to better understand it. So imagine you have three pieces of tissues. So this is the first flap. This is the philtrum. This is called the C flap, and this is the lateral lip. The concept was he inserted a rotational incision, and this is because after doing such an incision, we can rotate this part downwards, so we can rotate the philtrum downwards, okay? And this is called the C flap. The C flap will be used to close the nasal cell in complete cleft clips, so we can see it, how it is rotated and advanced to close the nasal cell. And finally, we will have here, once this is rotated downwards and this is rotated towards the nasal cell, we will have a gap here that we will fill with the lateral lip. So this is the advancement. The blue part is the advancement. This is why it has an advancement aspect. The rotation aspect is basically the purple part, which is the philtrum that will be rotated downward, giving us length. And so this is the whole concept of the rotational and advancement flap of Millard. Okay, as you can see also, we can see the Cupid's bow, how after rotating it downwards, we have it horizontal and at level. Basically, what is the problem with Millard's first technique is this, the scar that comes across the philtrum. So we have an oblique scar, and basically now we have the scar passing, it's crossing the philtrum. Instead of crossing it below, now it's crossing it above. So we can see also how the philtral column is oblique, and it's not two parallel, or actually not parallel, but at least two separate lines. So the Miller 2 technique came into play, where he did a less curved line. Okay, so instead of curving it directly, he made it a straighter line going upwards, and he inserted a back cut. What this back cut allowed to do is to free this philtrum part and allow the downward rotation of the philtrum. And he also added a transverse incision into the under the nasal aspect. So we can see this is the Miller 2 technique. This is a higher incision. It does not directly cross the middle of the philtrum, and also this is the back cut that was added. So I'll quickly describe the surgical procedure of Millard. So first we identify the bottom point, the lowest point on the Cupid's bow, which is above the tubercle. This is the central tubercle, as you can see. And we have a obvious point, which is the non-cleft Cupid's bow peak that we can identify visually. We mark it as 2. Then we measure this length. We project it on the other side to have the Cupid's bow on the other side. And then from there, we want the length of the medial column on the cleft side column, which is shorter, as we said. So in Millard, as we said, it is a rotational cut as we go method. So 5 is the point directly. It's the highest point under the nose, under the columella. And so we do a circular line that will join 3 and 5, and the back cut that was described also by Miller 2. So this will be the medial aspect, the medial marking of the lip. As for the lateral marking, so what we want is also the an equal length for the philtral column, because 9 and 8 will join with basically X and 3 in order to have an equal line, and 8 and 3 will both join to form the Cupid's bow peak on the lateral aspect, so the non-cleft Cupid's bow peak. How do we choose 0.8? So there are many ways in order to know how to mark 0.8. So first, they used to measure the height of the philtral column on the non-cleft side and project it on the cleft side, or the distance from the alar base to the Cupid bow peak, the length from the olar commissures, or finally, this is the right way, and this is the way that we identify it now, by identifying the Nordhoff's point that I will talk about it now. So what is the Nordhoff point? It's the point of the healthiest vermilion, and it is where the white roll is the most defined. So as you can see here, this point is where the vermilion is the healthiest. We have the thickest portion of it, and where we have the white roll most defined. And the reason why we want 0.8 that we talked about earlier to be the Nordhoff point, where it has these properties, is because it will become the Cupid's bow. So what is the Nordhoff's point? Basically, Nordhoff's point is the point where we have the healthiest vermilion and where the white roll is most defined. So why do we want 0.8 to be Nordhoff's point? It is because 0.8 will be in the middle of the lip. It will be the bow. It will be the peak of the Cupid's bow on the non-cleft side. So we want it to be well defined, just like it is on the medial side, so that our middle lip will have the best quality and symmetry. So basically, the way we choose Nordhoff's point, it is we have 2 ways. So we can see the cutaneous white roll when it starts to fade. As soon as it starts to fade, before it, where it has the healthiest cutaneous white roll, this would be our Nordhoff's point, or we can see it by looking at the convergence of the mucosa. So when the mucosa starts to converge, this is where we know that our Nordhoff's point has been passed. So the Nordhoff's point is right before the mucosa starts to converge and gets thinner. So then Muller's modification came into play. So what he wanted to do is basically also he wanted to so this scar right here that is crossing the middle, he wanted to further modify it in order for it not to cross the middle at all. So what he did, he extended his incision up into the columella, and then inserted a back cut from the columella into the philtral ridge. So we can see this is Muller's final result as compared to Millard. So this is how he accomplishes a straighter, not oblique and non-converging philtral column. So this is Muller's multiplication. We can appreciate how it goes right up into the columella and has the black cut going down. So these are the results that were published by Muller. So 74% of the cases he did, they had a straighter filtral column as opposed to the minority, which also converged. So basically, Millard and Muller's modifications, they are both rotational and they both face also the same problems. So first, let's start with problem number one. We can see here both have complex scars beneath the nose. So what this does is it in the future the patients always will need a secondary rhinoplasty surgery. So this will be the scar of their cleft lip, and this will cause them a difficulty in putting in using this old scar in order to perform the rhinoplasty. So what they will do is they will have to use a second scar for the secondary rhinoplasty, and thus we will have now a double amount of scarring, and it will further complicate things. So first of all, it complicates the placement of the transcolumnar incision at the time of a future open rhinoplasty. And the second problem is the Nordhoff's point. It will be compromised. We often have it compromised using the rotation technique, and we have a shorter lateral lip. So I will explain what I mean. So let's say this is the Nordhoff's point that we picked. So it is 0.8. 0.8 is the Nordhoff's point. But the length, in order to match the length on the non-cleft side, the length will surpass Nordhoff's point very frequently, and we will end up with a point that is surpassing Nordhoff's point, which is 8 prime, in order to have the same length as the medial aspect of the lip. So this would cause us two problems. First of all, we compromise the Nordhoff's point, so we do not have the highest quality of the lip. Second of all, we have a short lip. So as you can see here, we have here, this is the short lip, okay? So these are our two problems. And this problem is because we cannot control where we want the placement of 0.8 to be. So to address these concerns, Fisher's modification came place. So what he did, he canceled the rotational incision by Muller and Millard. This is his new incision that we will, of course, describe in details. And so this is, in general, Fisher's modification and Fisher's markings. So we can see what he did. He mainly got rid of the rotational incision, so we do not have any more an incision crossing the columella, the philtrum, or even going into the columella. And we can see the addition of two triangles. We have the C triangle and we have Nordhoff's triangle that I will explain the significance of each. So these are the two triangles. As you can see, these are the two back cuts for the triangles, okay? So first of all, this C triangle. So what would be the goal of the C triangle is, of course, to give a gain of length for the medial aspect of the lip. And this triangle, he managed to keep it always under 3 millimeters. Why? It is because also he created this pivotal point in which once this angled pivotal point also becomes straight. So this is a small theory from the Thomson effect. So when a curved or actually an angled line becomes a straight line, we also have a gain of length. So these are the two things that contribute to a gain of length: the C triangle and the pivot point here that will eventually straighten up. And this is Tennyson and Rendell. Some of you will tell me that it's exactly the same as Tennyson and Rendell, but in fact it is not, because here the triangle will always be large, and this will cause a triangle that will cross the filtral column. And mainly I personally accounted to the pivot point. So Fisher's technique added this pivot point that maintains now this triangle, the C triangle, under 3 millimeters, and thus we will not face the same problem as Tennyson and Rendell, which is a large scar going into the middle of the philtrum. So the second point that it will solve, it will help us always maintain the Nordhoff's point. So we will not compromise the Nordhoff's point. What will play a role in maintaining it is this C triangle right here. So if you can follow me right here, let's say this is the C triangle. Okay, so just to explain, A is the length of the filtral column that we want to achieve. B is the shortened filtral column, and then C is the distance that we will have to add to B in order to have a length equal to A, so that we are matching the full length and we are giving the slip the normal length. Okay, so B plus C is equals to A. What this small triangle will do, let's say we picked our Nordhoff's point right over here, and this is B plus C, it will give us a length of A. But let's say Nordhoff's point was here shorter. What we can do is we can rotate this triangle, and now we have the Nordhoff's point that we would like. So this is the Nordhoff's point that we want, and the gain of length will always stay the same. So it will be equal to B plus C, which is equal to A. So once we will open this, once we do this incision, and we will straighten it, we will always have a length equal to B plus C, which is A. So here we have the same gain of length, and we can determine where we want to put our Nordhoff's point. And also, just to explain, there's this triangle here that I will also explain. It's called the Nordhoff's triangle. So this triangle here, it's always good to insert a Nordhoff's triangle. It's called Nordhoff because obviously Nordhoff created this triangle. It is to insert it in the vermilion, also on the medial side. And this is because usually we have also a deprived vermilion on the medial side. So we add a triangular flap to it also to give it a gain of length so that everything is symmetrical and the vermilion will have all over the same width. Okay, so these are the two triangles. They are inserted in these two backcuts, and this is basically the Fisher's method. So this is the width. We want it of equal width. So by not doing it, we will have a Whistler's deformity. So Nordhoff's triangle also allows us to escape from this Whistler deformity. So basically, the Fisher's technique, just to summarize, it removed the transcolumellar scar under the nose. So as you can see here, we have transcolumellar scars. Here we do not have a transcolumellar scar. It replaces the gain in length from rotation to a small triangle. So as you can see here, we remove the rotational aspect, and the gain in length will be the small triangle. It uses Nordhoff's triangle to fix the vermilion height over here, and it helps us preserve the Nordhoff's point because of this triangle as we described. Now let's dive into details regarding the markings of Fisher's technique. So this will allow you to know how the markings took place. So first, we identify the lowest point on the columella, the junction between the columella and the philtrum, and then the borders. Then this is the lowest point of the Cupid's bow. This is the peak of the Cupid's bow on one side. We take the measurements. We go to the next side. We take the peak of the Cupid's bow on the other side. And then we go 1 millimeters above in order to skip the white roll. This is line A. Line A, this is the complete length of the filtral column. And again, 1 millimeter above to skip the white roll. And this is point B. First of all, this angle will create us the pivot, and line B is the length of the short columella that we want to lengthen. Now we find the difference between A and B, which is C, and this will be the size of the triangle that we will want to insert laterally into B in order to give it a gain of height of C, so that B plus C will be almost equal to. So as we can see here, we can see that C is equals to A minus B minus 1 millimeter. So basically, The minus 1 millimeter is accounted for the pivotal movement, the rotational movement that offers 1 millimeter in length. So as we can see here, also, this is the back cut for the Nordhoff's triangle. Basically, the back cut goes from the peak of the Cupid's bow to the lowest point. These are some markings also that we will use. So this is the marking in the alar crease, and also this is the marking in the nasal cell, the border that joins the columellar column. This is Nordhoff's point. So let's say we knew how to choose Nordhoff's point, just as we said, either from the white roll, so we have the healthiest point before the white roll starts to fade away, or before we have the convergence of the vermilion. This is the length, so we can just make sure that the length are equal so that we do not have a short lateral lip. These are the two triangles that will be inserted. This is the C triangle, and this is the Nordhoff's. And then we can project B. So as you can see, we projected B. So this is the width of the nostril that we have it on the normal side. This is also equals to the width of the nostril that we took the measurements of. So this will be the future width that we want. And basically this is the distance. This is the extra distance that we want to remove, okay? So basically these are the borders. This will come with this, and all of this part will be removed in the middle, all right? And so this was an example on an incomplete cleft lip. Now this is an example on a complete cleft lip. So basically the same markings. And as we can see, we can play with the triangle. This small triangle right here is whenever if the Nordhoff's point is here, and this is the whole length of A, we still have an extra piece of skin up, we can excise it in a triangular fashion. Basically, this is Fisher's technique. This is before and after by Fisher. So in conclusion, Fisher's technique uses anatomical supplementary pair. It relies on 25 landmarks, as we saw, as opposed to mirrored cut as you go method. We have no scar in or below the columella, and no scar around the ala also. He cancelled this scar. It allows to choose ideal position of Nordhoff's point, as we said, regardless of the height or gain in height that we want. And it's based on the theory of measure twice and cut once. So these are the major techniques for the complete cleft lip that are being used nowadays. So some surgeons are going with the new Fisher's method, but it's they find the markings complicated. So others are going with the Millard technique, and they are using the Nordhoff's triangle as well as the C triangle. So they are using both triangles in their new technique. So basically, the medial incisions, they are still sticking to the rotational incisions. So for example, this is the molar. As you can see, it goes up into the columella, or some of them are using the Miller, where it crosses across the columella, across the philtrum, doesn't go into the columella. But as for the lateral lip, what they are doing is they are using this C triangle in order to further contribute to a gain in length, and the Nordhoff's triangle in order to contribute to a gain in length in the vermilion. All right, so basically, if we want to summarize the markings, first we have the Tennyson, in which we insert a lateral triangle into the medial aspect in order to give it a gain of length. Then we had the Millard, the rotational movement. And then the molar, where instead of going with the incision directly through the obliquely through the columella, what he did, he through the philtrum, what he did, he went above into the columella, had the back cut in order to avoid this oblique scar. And finally, Fisher came into play. And nowadays, whether the surgeons are using the Millard, the molar, or the Fisher, what they are using is the the medial markings for each technique, but they are adding to it the advantages of the C triangle and the Nordhoff's triangle for all the techniques, because the C triangle will further give us a gain of length, and the Nordhoff's triangle will correct this vermilion deficiency. All right, so now we'll shift to the surgical approach and the marking for the incomplete cleft lip. So the obvious difference between complete and incomplete is the intact nasal cell and this extra piece of tissue in the incomplete surgical cleft. So what to do with this excess intact skin? I came across this article that was written by Mulliken. So in this article, he actually, after sub-classifying the incomplete into minor form, microform, and mini microform cleft lip, he described surgical techniques for each of these sub-classification. So first, let's just refresh our memory. The mini microform, it is where the notch or the difference in height between the cupid's bow peak, it's still the same, so no difference in height, just a small notch here, a small notch in the vermilion. We start to have the column to slightly fade away, and then in the microform, we have a difference in height, but it is less than 3 millimeters. The other deformities are more exaggerated, and in the minor form, finally, the difference is more than 3 millimeters, and we have all of the other deformities even more exaggerated. So we will start with the mini microform cleft. So the surgical technique that he proposed is just a simple lenticular excision. So a lenticular excision, so it's as if we're doing curvilinear lines, incision, just to remove this small notch over here, and in order to approximate or make this nasal cell less wide, okay? And it can also be done in the nasal cell by a Y to V incision or advancement. So this is the lenticular incision here and here that he used, and we can see the result in a mini microform left. And here there is no need to correct the muscle because we still have very small muscle deformity, and this is the 10 years later result of the lenticular excision. As for the microform cleft, so now we have a difference in height, but it is still less than 3 millimeters. So what he designed is a double uni limb Z-plasty, or it's actually just fancy for two triangles. So this can be, it's just, it has the same function as the C triangle that we saw earlier with Fisher. And this has the same function also as the Nordhoff's triangle because it is on the vermilion. So this triangle obviously will be used to give a gain in length for the medial aspect, and this triangle will give a gain in length for the notch here and for the vermilion, and this is what we will result in. And as for the nasal cell, what we can do is a Y2K advancement because we would have it here more severe and wider than the past form. Okay, so here the trick is, so let's see how it was done. So what he does is he measures the difference. Obviously, the difference will be slightly less than 3 millimeters. And then what he does is we free the overlying skin. Okay, so we free the skin. We cut and reapproximate the orbicularis oris. So this is unlike the first deformity, the mini microform. This microform, in this microform case, what we have to do is we cut the orbicularis and reapproximate it because, as you can see here, the column started to fade away. So this means that we have a poorer muscle concentration over here, and we will have to correct this deformity. So he also described actually to put this is a dermal graft in order to further define the column on this side, the filtral column, but he did not really describe it into further details later into his techniques and did not actually show us a before and after. I'm not sure, for example, in this technique, if he used the dermal graft or not. So This is the before and after. This is a 4 years old with a microform cleft. So we can see the after. This is the after right here. Okay, so he used a double unilimb Z-plasty. And finally, for the microform cleft, so here we have a difference of more than 3 millimeters, and thus the triangle, we cannot use the C triangle right over here. Why? Because as we said earlier, if we use a C triangle that is larger than 3 millimeters, because the difference in height that we want to give here would be larger than 3 millimeters, we would have the same effect as the Tennyson and Randall that we do not want, which is the large scar in the middle. So basically what he did is he adopted the rotational advancement technique of Millard. So this is exactly like Millard. So we can see this is the rotational incision, but here we do not have to go and extend the incision right across the philtrum. We can stop it halfway because the gain in length is not so much as for more severe incomplete cleft lips or the complete. And as you can see here, we already have an intact nasal cell, so we do not really need a C flap, right? So this is as if we already have a C flap rotated, so we do not need the C flap. All we need is a rotational incision in order to rotate the philtrum downward, and the C triangle that would contribute to a addition of height of less than 3 millimeters, and the Nudolph's triangle that will fix us the vermilion discrepancy that is present on the medial lip. All right, so this will be the final incision, final score after we close. So this is the before and after. As you can see, this is 9 years later, so you can see very beautiful results. As for the Fisher's technique for incomplete cleft lips, so as we discussed earlier, basically the only difference is that here we have excess skin, and the Fisher technique basically excises this excess skin. So what he does, he sees the radius of the nostril on the non-cleft side. He projects it on the cleft side. So this is the radius that we would like to have. This is the extra length of radius because of the deformity that widened the nostril. This is what we want to excise. Basically, this is all that is excised. So an incomplete cleft clip by the Fisher technique, you can see the after result. Also, it is quite beautiful. And here, the preservation technique. So basically, with Fisher's method, what we do is we excise the nasal cell. There's a theory where excision of the nasal cell will cause stenosis. So the preservation technique came into place. I came across this article that was published in 2024, in which they used the exact same marking as Fisher, but instead of doing an excision in the nasal cell, so to avoid an excision and avoid the risk of nostril stenosis, what they do is an incision. So basically, this is the only tissue that is excised. Over here, we do not excise, we only incise in order to be able to rotate inwards. It will have the same effect as an excision, but the only downside is that we will have excess skin into the nostril because rotating it upward will cause this and this excess skin to basically crumple up over here. So they described a simple method for it, which is just to apply sutures to depress the excess skin, and with time the excess skin will fade away. So this is actually a preservation technique where we preserve instead of excise excess skin and mucosa, and it is to avoid stenosis. So this is an after photo 8 years later. So now let's shift to the dissection and the release of orbicularis from the abnormal attachments. So we did our incisions with whatever technique we chose, and now we should free the abnormal attachments of the orbicularis. So just a small reminder, the medial abnormal attachment of the orbicularis oris is on the caudal nasal septum cartilage, and it's on the anterior nasal spine, so the bone that we will see. And as for the lateral attachment, we have the lateral attachment on the lateral crus of the lower lateral cartilage and on the piriform bone. So this is what we do. This is what should be done. It's to free the orbicularis from these abnormal attachments and then to let them meet in the midline again. So on the medial non-cleft side, what we first do, we start the dissection. So first we want to free the orbicularis oris muscle. We free it from the skin and from the mucosa. We go up to 1 millimeter and 1 millimeter only in order not to disturb the filtral dimple. Okay, and then what we also want to do, so as we said, we want to free the abdominal muscular attachment. So we release the orbicularis oris muscle. So we dissect and we reach the nasal floor, we reach the nasal septum, we cut the attachment from the caudal septal cartilage, from the caudal side, so from the downward side of the septal cartilage, from the anterior nasal spine, and some attachments on the alveolar bone. And this is how we free the medial aspect of the orbicularis oris muscle. As for the lateral side, so also what we do is a dissection. We can go up to 4 to 5 millimeters from the edge. So we can dissect the orbicularis oris muscle from the underlying mucosa and overlying skin. And then what we do is we want to start to cut in this groove in order to reach the lateral grooves. So here we can see the incision. Our incision can go up inside to reach the inferior turbinate, and we do this for two main purposes. So the first main purpose, if we can look here, so here we reached the lateral cruise, we free the lateral cruise from its underlying attachment, and we free the orbicularis oris muscle from attaching to the piriform bone and from the lateral cruise. And then we go on and we further free all the tissue in a supraperiosteal manner, in the supraperiosteal plane, in order to free this lateral cheek, and in order to be able to move it, so then when we want to move this side medially, the lateral side, when we want to move it medially, it is freed and tensionless. Okay, so this is why we extend our incision. We go in a supraperiosteal plane, so above the periosteum. We try to free the tissues so that when we want to exert medial tension on it, we will not have tension while closing the wound. So we can see here, for example, Slater's method, where he uses the cautery needle, and you can see the extent where he goes. So he goes up to the infraorbital region to free the tissue. And now let's move to the nasal floor closure. So in a complete cleft lip, what we have is an open floor. So there are several techniques that are very poorly described, honestly, online for the closure of the nasal floor, but some obvious ones. We can use the mucosa of the lip. So we have this M flap and the L flap, which are on the medial and lateral lips. What we do is we raise them and we suture them in a floor-like manner to provide a floor. And this is, for example, taken from Nordhaus's article. So what he does is he raises a turbinate flap. So this is the mucosa from the inferior turbinate. This is the mucosa from the lateral lip, the B mucosa. So he twists the B flap in this manner, and then he sutures it to form a floor. So here we have a floor. He flips the floor, and now this is how we can close the nasal floor also. And finally, we can also use simply the mucosa from inside the nose, so from the medial and lateral aspects of the nose, nasal mucosa. This is actually a cord cuttings 3D video on how to close the nasal floor, so we can watch it. We can see here is the nasal mucosa. And here also we can see how he actually frees the attachment of the muscle to the piriform bone. So this is freeing the orbicularis oris muscle from the piriform bone, from the piriform aperture. And this is how he closes the nasal floor. All right. Okay. As for the primary nasal correction, so the goal in primary rhinoplasty So this is while performing the cleft lip repair, the goal is to fix these abnormal cartilages. So we want to reposition the lower lateral cartilages of the nose. We do not really touch the upper cartilages or the nasal bone. So what we do first, the goal is to free this cartilage. After freeing it from the surrounding attachments, what is done is we reposition the cartilage. So repositioning the cartilage into the right position. After repositioning the cartilage, we fixate the cartilage to the skin. So now we'll see how. First, we start with the nasal septum. So the problem of the nasal septum, as we said, it is the caudal part of the nasal septum is attached to the orbicularis muscle on the medial side. So we have two situations. The first one is where we will have the bending of the nasal septum towards the non-cleft side because of the attachment of the orbicularis muscle, or we have the dislocation of the nasal septum from the anterior nasal spine. So the correction, basically, first we free the muscle attachment from the nasal septum, and then after freeing the muscle attachment, what we do is we can relocate the dislocated nasal septum into the anterior nasal spine. And here we can see the repositioning of the nasal cartilages. So before repositioning them, we want to free them. This is the technique in which we free the nasal cartilages. So we have two techniques. We either have the closed technique where the access points is the medial and lateral incision of our cleft lip. So we can see how we do not do the incision on the rim. We actually access it from the incisions. Or the semi-open approach in which we perform incision on the nasal rim. And in order to directly visualize the cartilage, to free the cartilage, and here, for example, you can see how we can directly visualize the interdomal region that is not possible with the closed approach. And we can also remove fibrofatty tissue from within the interdomal region, because when we want to close the interdomal angle, it will give a better outcome. But of course, everything comes at its cost. So here, at the cost of directly visualizing the cartilage, what will happen is, for example, this is a consequence of the semi-open approach, where as the baby grows, we can see here the notch that we will have in the soft triangle because we compromised or we caused a scar there by using the semi-open approach. So after freeing the cartilages, as we said, we want to reposition the cartilages. So the repositioning usually happens in a percutaneous method of sutures. So after we free and place the cartilages in the position that we want by altering them, we want to fixate them. So to fixate the cartilages, we place sutures that, for example, here we suture the medial cruras together. We can suture the dome together in order to reposition the dome of the depressed cartilage. What we can do is place a percutaneous suture to raise it. So, for example, this is how we are repositioning it in the position we want. So this is a percutaneous suture to the dome. We can also place a intercartilaginous suture. So this is the upper lateral cartilage. This is the lower dislocated lower lateral cartilage. To relocate it above, we can also put a percutaneous suture. So just a fast summary, we can see we can fixate it on the medial crura, and then we can put fixation sutures on the lateral crura, interdomal sutures, and finally we can put percutaneous ones. So this is Slayer's method. What he does, he inserts dragon velvet suture. So as we can see here, this allows him to raise the depressed cartilage. After raising it, what he does, he closes the orbicularis oris muscle, and he fixates the orbicularis oris directly on the anterior nasal spine while the nose is raised, and provides floor to support this the cartilage in this erect position. So after closing it, he then fixates the lateral lower cartilage in place and So we can see how the nose will be placed beautifully in place. Now, let's talk about the closure. So of course, it's a layered closure. We have the layers, the mucosa, the muscle, and then the skin. And this is the order that we go with. So first we close the mucosa. Then as for the muscular closure, we have the pars peripheralis. It is sutured in different ways in order to try to recreate the filtral column, as we will see. And the pars marginalis that is in the vermilion, this we keep intact to avoid the notching of the vermilion, so we don't really try to superimpose it. So for the portion which we try to recreate the filtral column, so we can do one of two things. So Moller, for example, describes to overlap the lateral muscle on the medial one in order to try to create, so we put them above each other to try to recreate a column. Or we can do apposition by doing horizontal matrix sutures and to do the apposition of the muscle in order also to recreate a filtral column. Now, moving on for the final part, the bilateral cleft lip repair. So here are the problems to solve that we did not really have in the unilateral cleft lip. So first of all, we have a protruded premaxilla. There's complete absence of the orbicularis oris muscle, and we have a short columella and a hypoplastic prolabium. So as you can see here, we don't really even have a columella that is visible. As for the anatomy of the orbicularis muscle and the complete, so it's the same as if we have it in the cleft side or the lateral side of the incomplete. So basically we have bilateral attachment of the orbicularis oris muscle to the piriform aperture and to the lateral crus of the nose. And as you can see here, the prolabium is devoid of any orbicularis muscle. So the evolution of the repair. First, surgeons started by doing a staged repair where they first corrected one side and then the other. And this was because of the protruded premaxilla. There was no enough skin in order to be able to suture both at the same time. So what they did was they corrected one side and then the other. But what this did, this stage repair caused asymmetry, and thus they realized that the first step was to correct this protruding premaxilla and then to correct bilaterally at the same time the mucosa, the lip. So the first step, as we said, is the correction of the premaxillary protrusion. And obviously, as we discussed earlier, it can be done through presurgical molding. So it can be done through the NAM or the LATAM devices. We'll see before and after photos of it. So as we saw earlier, this is the result of using a NAM device where we can, first of all, put the protruded premaxilla in place. And this is actually using elastic with the NAM in order to set back the protruded premaxilla, align it with the alveolus. So here we can see the use of the NAM. So this is the before, this is the after. And as for the LATAM device, also we can see the before and after. Now let's just to the chyloplasty. So we finished, we corrected the protruded premaxilla. So this is no longer a problem. The rest of the problems are we have no orbicularis muscle. So because we do not have an orbicularis muscle, also we do not have a white roll and we do not have a tubercle. We have a very short columella and very wide nostrils. So just by looking at this picture, to try to imagine how we will be able to correct this deformity. So where would we get the white roll and the healthy tubercle in order to fix it, to fix the deformity in the middle? So we would get them from the lateral lip. All right. So basically the technique will be getting the healthy white roll and the tubercle from both lateral ribs, getting them to meet in the middle. So here we have the healthy tubercles. So we will use the prolabium skin here in the middle to reproduce the filtral column and the dimple. And then we will medialize these depressed cartilages so they are unzipped, we can imagine zipping them up. What it will do first, it will give us a gain in length in the columella, and it will also make our the nostril thinner, and it will give us a nasal tip. As for the orbicularis muscle, so they are both situated obviously in the lateral lip, so they should meet in the middle also to reproduce the muscle. So we will discuss Mulliken's technique for the bilateral cleft clip, which is the most common technique being used nowadays. So first he uses the cupid's bow and median tubercle constructed from the lateral lip. What he does is he positions the lower lateral cartilages to define the nasal tip and columella, so zip the unzipped cartilages, and the lateral orbicularis muscle obviously sutured in the midline. So just to understand the markings, we define some points. This is the subnasal point, okay, directly under the columella. That's at the columella filtral angle. We have the subalaris here, all right? The crista filtri superioris, so basically the cupid's bow peak. The lowest point at the cupid's bow, which is the labial superioris. So first, the markings. The subnasal point, we identify it, and then in order to know the height of our prolabium, so in average, if the baby is around 5 to 6 months of age, what we do is we measure 6 to 7 millimeters in length. This would be the height of the required prolabium. Okay, so this point would be the labis superius, the labial superius. This is the lowest point on the cupid's bow. And then to measure the width, so also on average, if the baby is 5 to 6 months old, the width would be 3.5 to 4 millimeters at the bottom, and superiorly it would be 2 millimeters. So it starts thinner and then it widens up. It's important to note also, so this will be the skin of the middle philtrum, but we do not really discard all of this away. What we do is we keep 2 to 3 millimeters of dermis, so we only deepithelialize it up to 2 to 3 millimeters right here in order to have better vascularization, and also this thicker part, which is the dermis, will recreate the filtral column. Now we finished with the markings in the middle. Let's move to the lateral lip. So what we want to do is we first identify Nordhoff's point. Why? Because we always want the healthiest white roll and the healthiest amount of tubercle, because these two will meet in the middle to form, this time they will form the lowest part of the cupid's bow. So once we identify this point that will meet in the middle, we go 3 millimeters by 3 millimeters away in order to identify what this time we want to identify the peak of the cupid's bow. So these will represent the peak of the cupid's bow. And this distance must be equal to this distance, because this will be the cupid's bow, and this distance must be equal to this distance. Okay? So this is the final markings of Mulliken. This is what it will look like. So as we can see here, just to repeat one more time, these are the filtral ridges we can see of equal length. So the length are color-coded. These are the sides of the cupid's bow from the lowest point to its peak. We can see the length in purple. So this is the middle point, and then 3 millimeters go to the back to identify the peaks. Okay, so basically this is it, and this is the width of our nostril that once it meets with the yellow line here, we'll finally get this result. So we can see first we started with the prolabium, the deepithelialization. So we can see the 2 to 3 millimeters kept here, the intact prolabium that we kept in the middle, and for the rest, this we discard the skin. We are left with a mucosa. So what we do with this mucosa is we fold it upon itself, and in order to make it smaller, more compact, and we suture it to the anterior nasal spine. or to the prolabium, basically, on the premaxilla. This will create the posterior wall of the gingivolabial sulcus. We can also perform gingivoperiosteoplasty. I will show how. So this is an example, a live example of how we fold the prolabium to further compact it and to form the posterior wall of the gingivolabial sulcus. Gingivoperiosteoplasty, why? It's because we have a defect here in the alveolus. So if the prolabium is very close to the alveolus, what we can do is we can raise subperiosteally here. Why? It's because we want the periosteums to be sutured to each other because they have the ability to of growth formation, of bone growth formation. So this is what we do. We suture the gingivas together, but in a subperiosteal plane. So we raise the periosteum with the gingiva, and then we suture them. And now we're done with the prolabium. So as for the labial dissection, so just with the unilateral cleft lip, what we do is we dissect extensively. We reach the first the piriform aperture. We free the orbicularis muscle from the aperture, and we free it from the lateral crus. We also do an extensive freeing to free up to the we can go up to the malar or up to the infraorbital region. So we free the tissue because once we want to close and approximate both sides, we want them to be tension free. As for the closure, so here we can imagine from inside the mouth posteriorly, this is when we advance the lateral lip. So when we advance the lateral lip, this is the mucosa. What we do is we suture it. We suture the advancement in order to have this part in a tension-free state. This is the posterior wall. As you can see, the posterior wall will be sutured to the prolabium in part. So we can see how the posterior lip margin started to form. Then so here we can imagine how we finished the closure of the mucosa. Then we go into the muscle closure. So here we can suture normally the muscle. We do not have to oppose it or to put one above the other because we are not trying to recreate a filtral ridge in the middle. After closing it, we also close the tubercle, and we often have an excess tubercle, so we will have to trim the tubercle in the middle in order to recreate the medial tubercle. As for the nasal correction, so in the unilateral cleft lip, not all surgeons advocate for a nasal correction, but here it is necessary because actually the columella is in the nose. So because the nose is unzipped, to gain back our columella, we have to zip again the nose and to have the columella length back to its normal length. So as discussed earlier, same semi-open versus closed approach. So here we can see McComb's technique. So what he does is an incision above the rim, so it's on the skin. You can see this incision. So what he does, he raises the skin, and this better allows us to visualize the interdermal region to remove the interdermal fat and to close the dome. And here it's important to be able to visualize the interdermal region because we want to remove whatever is in between in order to be able to close the cartilages and approximate them good in order to zip it the right way. So Mulliken also described his alar rim incision. Tajima described an incision in the soft triangle, but honestly, all of these incisions, they all have consequences that a surgeon should be aware of and weigh the benefits of these incisions versus the consequence of the scarring later on and the stenosis that they might cause. So McComb's approach, we can see this is the scar that it will cause. These are examples of the scars by McComb's. And then, so as we said earlier, after we free the cartilage, what we do is we apply suture suspension to these cartilages in order to fixate them, so we can put it on the lateral cruise, on the medial cruise, dome, and interdomal. Here we can also apply cinch sutures. Why? Because we are fixing both both alas, so we want them symmetrical. So what the cinch suture does is it ensures symmetry. So it will approximate in an equal manner both sides in order to ensure symmetry in the radiuses. And this basically it goes to the dermis of the alar base. It passes under the filtral flap and is tied to narrow the interalar dimension to around 25 millimeters, and the goal is to reorient the alar rim symmetrically. We also have something called the Myrti-form sutures. So these sutures, they are secured to the periosteum of the premaxilla, and it's near the canine fossa, and then we secure these sutures to the midpoint on the nasal sill, and basically their function is when smiling, it prevents the alar elevation and it depresses the nasal sill. As for the redundant skin, so after closing everything, we'll have an extra skin. Some surgeons, they advise to remove it, others advise to keep it to avoid stenosis. So the only way we can know is a 10-year follow-up to weigh the benefits versus the complications that they encountered. And finally, these are some beautiful cases done in our institution by Dr. Shadi Moore. He's also an attending surgeon at the American University of Beirut. So we can see the beautiful results of the bilateral cleft clip that he has done. And in conclusion, there are several variations and modifications that exist. Each modification aims to improve outcomes, but impact can only be determined by long-term follow-up, so 10 to 20 years, and assessing the functional and aesthetic results after this small move has been done. So use previous data to determine the consequence of each move 10 to 20 years in the future. And finally, as everyone says, less is usually more. Thank you. I hope you liked this presentation. I will try doing more presentations regarding plastic and reconstructive surgery topics, after, of course, doing extensive research into them and to group the information in a nice and simple way in order to deliver them easily in such videos. Thank you. So these are my references.